We'll go ahead and get started in the interest of time. Pleased to welcome today to our MPRINT Webinar Series, Dr. Gretchen Bandoli. Dr. Bandoli is an assistant professor in the Center for Better Beginnings at the University of California, San Diego, where she received her PhD in epidemiology at the University of California, Los Angeles in 2015. And her research and training focused on pediatric and perinatal epidemiology and epidemiologic methods. She also had a TL1 fellowship with the Center for Better Beginnings, where she researched maternal psychological health and neurodevelopment in the offspring. And today she is going to share with us her work on prenatal acetaminophen use and offspring neurodevelopment, a summary of the literature. Dr. Bandoli, welcome.
Great, thank you so much. All right, so we'll go ahead and jump in here. So thank you for the opportunity to present this work today. So as mentioned, I'm going to be talking about prenatal acetaminophen used obviously by the mother during pregnancy and the risk of adverse neurodevelopmental outcomes in the offspring. So this topic may be familiar to some of the people on the call. There's been this growing literature that's reported out a positive association between acetaminophen used during pregnancy and adverse offspring outcomes, mainly around neurodevelopment and ADHD. And there's been kind of quite a lot of commentary back and forth about whether that's nothing more than an association or whether there's an actual causal relationship happening between prenatal acetaminophen and neurodevelopmental disorders in the offspring. And so that's what I'm going to go through today on my talk and just kind of present what the literature has presented to date and discuss kind of more in detail about where the hang up is between looking at the association that has been presented kind of consistently across multiple different studies and what we need to actually move that into be able to assess causality in that relationship. So to kind of establish just some of the background terminology that I'll use during the presentation. So when we're trying to establish causality, the main things that we worry about are exchangeability. So we need to make sure that the two different groups, so here we're thinking about an exposed group and an unexposed group, that they are otherwise the same with respect to their risk of the outcome, except for the contrast between the exposure. So basically, randomized controlled trials get at that by randomizing individuals, to either the treatment or the placebo or whatever the contrast is. In observational studies, we often lack that exchangeability. So then we move into a space of conditional exchangeability. So we want to say basically with the variables we have, conditioning upon them that these groups are exchangeable. So there's nothing else that's influencing the risk of the outcome between the two groups except for the exposure of interest. We also have to worry about positivity. So this is basically saying kind of for every combination of the covariates in the study that there's a non-zero probability of exposure across all of those covariates. We think about consistency, and so this is really around the exposure. It's also basically saying that there's no treatment variation, or that kind of said in another way that we have a very kind of good definition of that exposure. And so the exposure is well defined and is defined to a point where we can say that nothing else is affecting it, or it's not being kind of affected by other things. So examples would be, does it matter if it was taken during the day or during the night or with food or not with food? And so that's one of the things that has to be established or it has to be in place to establish causality, is the consistency of the exposure there. And then we also think about measurement error. And so just making sure that there's no misclassification of the exposure, the outcome, or other variables in the study. And so with respect to this literature that we're going to talk about today, the main kind of sticking points of establishing causality in this space are really around exchangeability. So making sure that we have that balance between exposed and unexposed groups and no measurement error. So those are the things we'll kind of focus on when we go through the literature. All right, so when we talk about exchangeability, there are kind of two things that are feeding into that. So we think about confounding. So that's when you have this third variable that's affecting both the exposure and the outcome, leading to a spurious association. And so we'll talk particularly in this space around confounding. We think about selection bias. So basically, did the way that we selected people into our study or the way that people exited our study change the contrast we see between the exposure groups in a systematic way that differs from what we would have seen if we had been able to enroll our entire target population? And then again, information bias. So what we talked about on the last slide, making sure that we don't have measurement error of the exposure or the outcomes. And those are two things that will be important as we talk about this literature as well. So as I say, as we kind of go through this, we'll really be focusing mainly on the confounding and information bias as potential systematic errors that could affect the results of these studies. So at the heart of this, we know that there's an association between prenatal acetaminophen and ADHD. It's been shown kind of time and time again across multiple different cohorts, and I'll go through some of the evidence, and you can see the the results that have been shown across these different cohorts in a little bit more detail on them. But that's fairly well established that association is there. The question is whether this is actually a causal association. So is prenatal acetaminophen causing ADHD? Or do we have something else that's explaining this association here, something like confounding? And the way that I tend to like to think about this, if we leave this space for a minute of prenatal acetaminophen and ADHD, and we think about an association like drinking red wine and cardiovascular events. So there's this fairly well-documented protective association between red wine consumption and this reduced risk of cardiovascular events. That association is there. If you regress cardiovascular events on red wine, you will see this protective association. The question is, did red wine cause people to have a lower risk of cardiovascular events, or do people who have red wine also have different factors, things like income, education, access to healthcare, other healthy behaviors that are actually affecting their risk of cardiovascular events? And red wine just happens to be a marker of those other things. So that's a space we're in here as well. The question is, if we actually intervened on acetaminophen, because that's what at the end of the day, that's what a causal association is saying if we were to intervene on prenatal acetaminophen, we would change the outcome of interest. So we would reduce ADHD if we intervened on prenatal acetaminophen. Or do we have something like this mechanism that I'm showing here, where there's actually the association of interest is noted by the absence of the arrow here between prenatal acetaminophen and ADHD, and it's actually being affected by this third variable here as U. And so then we can think through, well, what would U be? And so in this space where we're thinking about perinatal pharmacoepidemiology and acetaminophen in particular as an exposure, that U could be something like confounding by indication. And that's something we'll talk about a little bit more in the literature. It's been discussed kind of at length for this association. That could be something like genetic factors. So maybe people who already have ADHD are more likely to use acetaminophen, or maybe there's a genetic vulnerability that is predictive of the people who use acetaminophen and also would obviously affect the likelihood of ADHD and the outcome or of their offspring. And then there may be other systematic differences that we'll talk about that could explain that third variable there in this DAG. The other thing we'll talk about that has been kind of discussed at length around this literature is information bias, particularly around measurement. And so we'll talk about whether with this relationship between prenatal acetaminophen and ADHD, whether there's a reporting bias there, whether the literature may be biased by the fact that moms who report acetaminophen are also the ones who are reporting their child's ADHD, or conversely, whether moms who use acetaminophen are more likely to have their child evaluated for ADHD. So even if you're using a physician's diagnosis, maybe the children of moms who used higher amounts of acetaminophen prenatally are more likely to be evaluated for ADHD. And so we'll talk about that as we go through the literature as well. So the reason that this is of concern is that acetaminophen is considered the preferred over-the-counter analgesic for use in pregnancy. So particularly as people pass into the latter half of their pregnancy. NSAIDs are contraindicated. They increase the risk of things like oligohydramnios. And so acetaminophen really is the preferred over-the-counter analgesic. And you see that with the prevalence estimates here. Between 40 and 65% of women will use acetaminophen during pregnancy, with estimates ranging from 3 to 20% of women who report use in all 3 trimesters of pregnancy. And acetaminophen crosses the placenta and can enter fetal circulation, thus supporting that biologic rationale for acetaminophen potentially affecting the development of the fetus. So starting, I would say probably back in like 2012, 2013 timeframe, there started to be reports of this modest yet concerning associations between acetaminophen during pregnancy and select pregnancy and childhood adverse outcomes. And these were papers coming out of fairly large cohorts. So these were a lot of cohorts out of Europe. There were a few US cohorts, but primarily the cohorts looked at neurodevelopmental disorders, and they tended to look at ADHD, although as you'll kind of see as the papers come up, autism and some of the other neurodevelopmental outcomes were also measured in these. But so these papers were reporting fairly consistently and in large samples this positive association between prenatal use of acetaminophen and ADHD in the offspring. These were papers that were published, that received a lot of media attention, and they kind of just kept coming. They were done kind of in multiple different cohorts and replicated across those. And so when this is a summary done a little while ago, kind of at the time that this first wave of papers came out. What you can see here is that the papers are coming from different populations. So the Auckland Birth Weight Collaborative Study, the DNBC, so the Danish National Birth Cohort, ALSPAC out of the UK, this INMA cohort in Spain, and the MOBA birth cohort out of Norway. All were finding these very consistent associations between prenatal acetaminophen and different neurodevelopmental outcomes in the offspring. And so at the time, the kind of first reaction to these was that the categorization of acetaminophen wasn't great. So if you see, as you can kind of see here in the table, some of the studies were using or categorizing acetaminophen as just any use during pregnancy. Others were looking more at the number of weeks of use or use by trimester. Others were measuring acetaminophen at 18 weeks and 32 weeks. So there were kind of different operalizations of the exposure of acetaminophen there. And then there were other concerns that were raised about this kind of initial wave of studies. And these were that largely the studies didn't have a great capture of the dose. So a lot of these were a straight kind of count of days of use. Some of these were recalling acetaminophen after birth. And so, you can kind of think back to if I asked you how much acetaminophen you used a month ago, you probably couldn't tell me. And so now I'm asking you how much acetaminophen you used, 8, 9, 10 months ago. That is kind of ripe for misclassification there of the exposure. Another thing that was of large concern, and this will become important in a paper I'm going to show in a few slides, was that there wasn't this great capture of the indication of use. And so people knew women were using a lot of acetaminophen, but they didn't know why. And so as I said earlier, we tend to worry about confounding by indication for pharmacoepi studies. And the question was, is it the acetaminophen, or is it that the reason they're using the acetaminophen, the pain, the fever, whatever the cause of needing this analgesic, is that what is actually affecting the risk of neurodevelopmental disorders in the offspring? So following this kind of first wave of the studies, a consensus statement was published by several of the authors on those papers and others. And in this consensus statement, they went through and kind of summarized the evidence to date, both the epi evidence as well as animal studies, and looked at different outcomes that have been associated with acetaminophen exposure in pregnancy. So these included perinatal outcomes here, malformations. They talked about the risk of childhood neurodevelopmental outcomes, including ADHD and autism. And then they also talked a little bit about adolescent and adulthood outcomes from prenatal acetaminophen exposure, and these were mainly around the timing of the onset of puberty. So they also summarized the animal literature in this consensus statement and basically showed that the same kind of outcomes that you see in the human literature are also seen in the animal studies. And so this paper did a nice job of kind of, holding that contrast between the human studies and the animal literature. And so at the end of this consensus statement, they talked about that they believe that the potential for harm from continued inaction exceeds the harm that might arise from precautionary action. They did recognize the limitations of the existing epidemiological literature and the need for a rigorous meta-analysis. They went on to say that the EPI studies should be designed, future studies should be designed specifically to reduce confounding by indication. So it was, still recognized that was a limitation. Control for genetic factors, accurately capturing the exposure and the outcome, and then being able to examine timing, dose, and duration of the exposure, both prenatally and postnatally. But they concluded the consensus statement by saying that the precautionary action should be put in place now, including recommending that women should be counseled prior to or early in pregnancy with guidance around foregoing acetaminophen use unless it's medically indicated, that pregnant women should consult with their physicians or pharmacists if they're uncertain about whether the use was indicated or before using it for long periods of time, and that women should minimize the risk and use the lowest effective acetaminophen dose for the shortest possible time. So this consensus came out in 2021. This was followed by a response from the American College of Obstetrics and Gynecologists, who basically said, this is the advice we give anyway for any medications in pregnancy, but that acetaminophen has always been identified as the only safe pain reliever in pregnancy. They talk about neurodevelopmental disorders are multifactorial and difficult to ascribe to singular exposures, and they're not recommending anything counter to what is already said by OBGYNs when prescribing acetaminophen for given conditions. The FDA, this actually came out kind of before that consensus statement, but the last time the FDA reviewed acetaminophen, they maintain the same stance that with basically the summary that all of the studies reviewed had potential limitations to the design. They recommended that pain medications are used during pregnancy, or that the recommendations for pain medications used during pregnancy remain the same. And again, that same message that pregnant women should be consulting with their healthcare providers before taking prescription or over-the-counter medication. But at the end, and they'll continue to monitor and evaluate this, but at that time, no labeling changes were made. So following this, a meta-analysis was very recently done, which has, again, kind of put the topic back out into, I think, the popular press. So this meta-analysis that came out very recently summarized the evidence to date, and they found 23 cohorts with about 370,000 participants between the cohorts, of which about half were exposed to acetaminophen during pregnancy. Most of the cohorts came from Europe and the US. ADHD was the most common outcome evaluated and synthesized in the meta-analysis. Of the studies to date, they found about 14% were considered to be high quality. The bulk, 60%, were of medium quality, and then the remaining 25% were either low or very low in quality that went into the meta. And then the pooled risk ratio for ADHD, which you can see here at the bottom, was 1.34. And what you can see is that there are a whole lot of studies that didn't actually get pulled into this meta because they didn't have adjustment for covariates and the confound adjustment for the indication and that kind of stuff. And so what you see is that these 4 studies pooled into the meta-analysis and found this adjusted risk ratio of 1.34. So kind of breaking that down a little bit more, These were the studies that were initially looked at. So these are the unadjusted effect estimates. And you can see from the forest plot here that most effect estimates are to the right side of the null. When they then limited this to the studies that adjusted for maternal and infant characteristics, what you see is you lose a lot of the studies, but that there is some attenuation of other of these studies that start creeping towards the null when you adjust for maternal and infant characteristics. And then in the last pass on the studies that also had adjustment for confounding the reason for using acetaminophen, you can see that these effect estimates are, again, still approaching the null, but still slightly elevated. And that was kind of driving that effect estimate of 1.34. So we know that confounding, certainly from the unadjusted association, confounding is happening. We see this march toward the null as you kind of progressively adjust for different variables. But given the set of kind of common conditioning variables they had, this small effect of this 34% increase did remain. So to kind of summarize this meta-analysis, the main focus of this meta-analysis was really trying to get at confounding by indication. So there are a lot of indications or reasons why people use acetaminophen. The main kind of ones that are captured on these studies are fever or infection, inflammatory disorders, musculoskeletal or joint diseases, or pain. And they did a bias analysis. So they computed the equivalent of an E-value here, or basically what it's telling you is the strength of an unmeasured confounder, or something that's not in that you haven't adjusted for, that would have to remain and have the strength of the association both with your exposure, acetaminophen, and the outcome, ADHD, to negate the findings. And so the risk ratio for such a variable would have to be 3.0 or higher to negate the findings here. And so that's kind of around the confounding by thinking that confounding by indication is the bias that was most focused on in this study. The other things, though, to note from this meta-analysis is that the three studies I had mentioned earlier, the ones that were high quality, all three of those came from the same cohort, which was this Boston cohort, where they actually had assays of acetaminophen. So they assayed maternal blood at delivery, they assayed in 3 separate analyses, cord blood, and they assayed infant, I think, blood after delivery, and looking for analytes of acetaminophen use. And so those were considered the high quality studies. I do think it's worth noting, while that does get us outside of report and recall of acetaminophen, it doesn't change the fact that there can be that U that we showed in the DAG that is still confounding the association of acetaminophen and the outcome. So while having a biomarker of exposure does address measurement around the exposure, it doesn't account for some of the other things that we talked about that were missing for exchangeability. And then a lot of these studies didn't capture characteristics of acetaminophen users. So a lot of these studies are adjusting for things like maternal race, ethnicity, and age and income. But what I'm going to show you is that there are other covariates that haven't been included systematically across these studies. So with both the consensus statement and with this publication as well, this was picked up again by the media. And so you can see this is just kind of a quick capture of some of these that, back kind of in the common press, USA Today and CNN, and are warnings again to individuals that asking if Tylenol is safe, if Tylenol is linked to autism and ADHD, and probably predictably, it's making its way through the courts as well. So one of the issues that I talked about is who is using acetaminophen, and particularly what is the profile of someone using kind of high levels of acetaminophen? Because in the studies where they could look more at things like number of days of use and duration of use, there was a dose response there. So what you're really seeing is that the higher and longer amounts of use are associated with a higher risk. And so we had wanted to ask from our own data of whether we could better characterize the users of acetaminophen. So this is a paper we published several years ago with Christy Palmston and Tina Chambers, and this is data from the mother to baby cohort. And the objective here, as I said, was to describe the use of acetaminophen, update. That slide I showed earlier, that towards the very beginning of the prevalence of acetaminophen was fairly dated, and so we wanted to update in a US sample the prevalence of acetaminophen, and then look at the duration, the dose, the indications, why people were using it, and then sociodemographic characteristics and comorbidities that are associated with higher levels of exposure. So from the mother to baby pregnancy studies, we pulled data from 2004 to 2018. They collect, it's a very well documented cohort with information on the person's medical history, previous pregnancy outcomes, sociodemographic characteristics, the use of illicit and licit substances during pregnancy. And then we capture medications, and kind of importantly, these is done a couple times over pregnancy, so the recall isn't that long, for reporting these. And we characterize over-the-counter as well as prescription medications in terms of the dates of use, the dose, the frequency, the duration, kind of all of that stuff, and the indication for use as well. And so acetaminophen we characterize it in multiple different ways, kind of to make it comparable to some of the cohorts that were using more of the yes, no, and trimesters of use and that kind of stuff. So we looked at acetaminophen, starting with kind of this pregnancy diary approach, and then categorizing down into any use per trimester, cumulative exposure categories. That's done a lot, particularly in the European cohorts, of how many days of use someone used acetaminophen. And then we characterize the dose as well. So the results were that there were about 2,400 subjects enrolled, and 1,500 of them reported use of acetaminophen. So 62% of the cohort reported acetaminophen use at some point in pregnancy. Of this, 97% was over the counter. This is one of the reasons it becomes really hard to study this. We can't turn to payer databases that we like to turn to a lot, because they're not capturing over-the-counter use of products. And it was obviously the vast minority that were actually received through a prescription. Regular Tylenol, acetaminophen, and paracetamol were the most commonly reported for acetaminophen. Extra strength Tylenol came next, and then Tylenol was also abstracted when people reported cold and sinus preparations. Basically, kind of any combination product that had acetaminophen, we abstracted the acetaminophen dose out of, but that was the cold and sinus preparations were kind of the most infrequent. So when we look at the prevalence over the duration of the study cohort, you can see that acetaminophen has slightly tapered off in its use over time. And then when we look, and so as I said, we're now down slightly lower than 60%, but overall it was 62% of individuals used acetaminophen at some point in pregnancy. And then when we break this apart by use in the trimesters, what you can see here is that trimester 1 and 2 have basically the exact same in terms of their prevalence of use. And then there's slightly lower use in that third trimester. So we were interested in looking at the prevalence by trimester. What you can see here, this is of acetaminophen users. What you can see is 40% only used acetaminophen in one trimester, whereas 30% used in 2 and 30% used in all 3 trimesters. When we looked at the univariate analyses of analysis of characteristics of acetaminophen users, we found that there were slight differences by maternal race. So individuals who identified as white were more likely to report any acetaminophen use. In individuals who reported their race ethnicity as Asian were less likely. Individuals who were obese were more likely to use acetaminophen, and individuals who smoked were more likely to use acetaminophen. What we didn't find any difference on was maternal age, gestational age of enrollment into our cohort, education, socioeconomic status, income, whether the pregnancy was planned, whether they were using prenatal vitamins, or whether they were using alcohol. And so as we kind of think through the covariates that are adjusted for, that are available and adjusted for in a lot of studies, it is worth noting that in this pass through the data, we didn't actually find differences by a lot of the covariates that we adjust for. What we did find a lot of difference in were people's different mental health outcomes. So now you're looking at acetaminophen categorized by duration of use. So starting at someone who used for less than 10 days across gestation, all the way up to the highest category was 45 or more days of use. And what you see is when we look at a maternal report of a history of depression, you see that the more someone's using acetaminophen, the more likely they are to report a history of depression. Same with anxiety, same with being currently on an antidepressant, and same with when we collapse down other mental health disorders. It is worth noting that we did look at the EPDS and the state trait anxiety inventory, and there was no difference in those. So the current depression and anxiety symptoms did not differ by acetaminophen use. It was more of like the history of depression and anxiety, as well as being currently on an antidepressant, which may have affected then the symptoms of depression and anxiety. When we looked for the indication of acetaminophen, we found kind of as expected, most people were reporting use for headaches or migraines. The second highest indication was pain or injury, followed by cold, flu, fever, and then sleep and cramps were the lowest reported indication for use. And sleep may come as a surprise. So that is people were using Tylenol PM and reporting the indication for sleep there. So when we looked at how those indications varied by the duration of use, what you see here is that as people are using Tylenol for longer, they're less likely to be using it for things like having a headache or migraine. They're less likely to be using it for a fever, which probably isn't a surprise, but they're less likely to be using it for cold or flu. And the blue, where they're actually more likely to use Tylenol for extended amounts of time is if they're using it for pain or an injury, or whether they're using it for as a sleeper, as a sleep aid. That is a bit concerning because when we looked at the dose of the average acetaminophen dose per day, the indications that I just talked about where people are using longer duration, sleep is actually one of the highest average acetaminophen doses per day. So people were using on average about 1,000 milligrams a day of acetaminophen if they were using it for sleep. And pain and injury is kind of in the middle here at about 750 milligrams per day. But so, particularly for some of those indications where people are using it longer, they may also be using higher doses. And so the cumulative exposure is going to be much greater in those individuals. So when we compared our findings to previous cohorts, we found that so this is the mother to baby cohort was our sample compared to the Danish sample and the Norwegian sample. People were more likely to use acetaminophen for longer amounts of time. And they were more likely to use acetaminophen in all 3 trimesters in our cohort than in the European cohorts. The indications tended to actually be about the same, with the exception of sleep that wasn't reported in either the Norwegian or the Danish cohorts. The only other kind of takeaway from this was kind of a call to investigators to be careful with how they're categorizing acetaminophen. When we use the count of just trimesters, we found that could actually lead to a lot of misclassification. 57% of our women who reported use in all 3 trimesters had less than 20 days of exposure. So they actually were not amongst those with the highest exposure. And similarly, 40% of women who used for 20 or 44 days were not, or even 45 days plus, were not captured by the classification of all 3 trimesters. So using a count of trimesters is probably leading to a lot of heterogeneity in how much acetaminophen is actually being taken in that category. And so the kind of summary from our work was that women who used acetaminophen for that longest amount of time, the 45 days, had much higher prevalence of self-reported depression, anxiety, other mental health disorders, and use of antidepressants. This is important because these things could all also affect the offspring's risk for neurodevelopmental disorders, including ADHD. And that the higher doses and the higher durations were being reported for indications such as pain and sleep, which also may be comorbidities of mental health disorders and may also affect, again, the offspring's risk of neurodevelopmental disorders. A few more analyses that we've done in our group. We looked at prenatal acetaminophen use amongst women who have autoimmune disorders and looked at just the adverse pregnancy and birth outcomes. So I'm not going to actually go through the pregnancy and birth outcomes, but just to kind of show, I'm going to go through some dose information. So just as kind of some background information, Tylenol tends to be dosed. The regular strength comes in the capsules that are 325 milligrams. The extra strength is coming out of 500 milligram tablets, and the use guidelines are not to exceed 4,000 milligrams in a day. So when I show you dose information, that's kind of the background, of what people are using here, or the guidelines around use. So here we were looking here, and now we're looking only in a sample of women who have autoimmune conditions. And so they often have a lot of pain and inflammation and use analgesics likely more than people who don't. And so here we looked at acetaminophen use and broke it into quintiles. Just kind of for reference here, this highest quintile at the highest dose, this person was using about 3,500 milligrams of acetaminophen every day across pregnancy. And so that's kind of the upper bound of our exposure here. And what we found was that, again, BMI differed, where people who were using the highest in those highest quintiles were more likely to be overweight or obese. There was an education gradient. So people using the highest amounts were more likely to have less education. But this is, again, where we really get into that exchangeability. So people in the highest quintiles were more likely to be using tobacco. They were more likely to report fibromyalgia. They were more, and this is, again, an autoimmune cohort, but they were more likely to have RA or SLE compared to IBD, psoriasis, or other autoimmune disorders. Mental health comorbidities picked up again in this sample. So depression, anxiety, or other mental health conditions, a self-report of those were kind of dramatically higher amongst people who had the highest amount of use. And then other medications, so asthma medications, oral corticosteroids, and DMARDs were also highest kind of in this highest use group. And all of that is just to kind of reinforce the exchangeability, and are we able to kind of achieve conditional exchangeability in our analyses. The last one I'm going to show you is actually a student's thesis who looked at prenatal acetaminophen and neurological development through 48 months. So here she classified, this is again out of a mother to baby cohort. So acetaminophen was classified, and then we looked at tertiles of use. So you can see the kind of breakdown of the low, moderate, and high amounts of use. And this is a cumulative use across pregnancy. So you can see that the average daily use was very, very low. Again, you're taking a sometimes sporadic exposure and moving it all the way, spreading it all the way out across gestation. So low use was really quite low and was probably taken a few times over pregnancy. And the highest was at about 2,600 milligrams a day, so lower than that autoimmune cohort. Here we saw the exact same kind of things, that individuals in that highest use group were more likely to report other mental health diagnoses or depression. They were more likely to be using antidepressants, and they were more likely to be using ADHD medications. We only had 2 who were using in that group, and 2 in the unexposed, but the prevalence was double in that highest group. And so here we looked at some maternal reported outcomes. And so the ASQ and the MCHAT, so a screener for autism, and basically found here that there were no differences between the groups. So the adjusted risk ratios ranged between, for each of these different exposure levels, low, moderate, and high, back to the none. from 1.4 to 1.3, and they all crossed the null. And then on the MChat, the adjusted risk ratios ranged from basically 0.9 to 1.1, and obviously crossed the null. So in our sample, we actually didn't see any difference in these neurodevelopmental outcomes. These were done between about 6 months and 4 years. There was a wide age range here, but within the age standardized scales, we didn't see any effects on neurodevelopment. The last kind of thing I want to show you guys about with exchangeability to keep in mind is that this study came out in 2019, where they actually looked at the profiles of people who had different risk alleles. And so these are the maternal polygenic risk scores for ADHD, autism spectrum disorder, and schizophrenia. This is out of the ALSPAC cohort again. So they looked at the maternal genetic risk score for ADHD, autism, and schizophrenia, and then they looked at how exposures differed in those groups compared to people who didn't have the high polygenic risk scores for these same outcomes. So it's not saying the mom had ADHD, they just have a higher risk based on their polygenic risk score. And what was really interesting was that mothers who had a high polygenic risk score for ADHD were more likely to use acetaminophen in pregnancy than mothers who didn't have that, that genetic risk, basically. That was not seen in people who had the higher genetic risk score, the risk alleles for autism or schizophrenia. But as I say, it was in people who had the risk alleles for ADHD. So where does this leave us? So kind of moving forward, I would argue at this point, we can keep doing cohort studies. We will probably see the same thing over and over. This, the association that has been reported is consistent, and it's been seen across multiple different studies. There's probably some publication bias in, what gets published and what doesn't. But in general, if we keep drawing and doing these same study designs over and over, I think we'll keep seeing the same things. The meta-analysis was fine, but if you have systematic bias in the underlying literature, all doing a meta-analysis is going to do is basically tighten the precision around a biased estimate. And so in my mind, the meta-analysis isn't doing that much to really kind of move us from an association into establishing causality. And so from my point of view, we need to start thinking about other study designs. And so I'm in the last few minutes just going to talk about a couple of those. So the three I'm going to talk about are a sibling analysis, organoid models, and negative controls. So for the sibling analysis, what we do in a sibling analysis is we actually leverage discordant sibling exposures. And what that does is controls for the stable family and individual level factors. So you basically, you take your whole cohort, you pair up SIBs, and the sibling sets that give you information are pregnancies where the exposure you're interested in is discordant. It was only used in one of the two pregnancies. And those are the siblings that really contribute into being, or the information that contributes into being able to evaluate the exposure while controlling for those kind of maternal and family level factors. So the MOBA, previously, the Norwegian cohort MOBA had found an association and reported on it between acetaminophen and ADHD. They went back in 2021 and did a sibling analysis. And they found that in the sibling analysis, there were no effects observed between acetaminophen and ADHD at any level of use. And so kind of what you can see here is that this was the kind of unadjusted association where you see what we've seen in all the cohorts, where longer duration is associated with these, kind of twofold higher hazard ratios in this case of ADHD. In model 2, they adjusted for the maternal characteristics that I talked about, and you see some attenuation, but we continue to see this dose response. When they then limited it to the SIB sets, everything attenuated to the null. And what this last model is showing you is the family effect. And so basically what this last model is showing is that women who used acetaminophen in at least one pregnancy, their child, irrespective of if they were in the exposed pregnancy or not, were almost 3 times as likely to have a diagnosis of ADHD compared to kids whose mothers didn't use acetaminophen. And again, it's irrespective of whether they were in the exposed pregnancy or not. And so that really is kind of that family level effect that's being shown and basically kind of explaining away that association. Sibling studies are hard to do. You need a really large data set, and there's always question of why was an exposure done in one pregnancy and not in another pregnancy. But I do think that we need to continue to move in that direction, because I think that those kind of maternal level factors are hard to adjust for otherwise, and the sibling control provides a fairly robust adjustment for those factors. Another path that we've been exploring are organoid models. So this is like a complete 180 from the epi studies I've been showing you. But this is some work here at UCSD from Alison Motri and his project scientist. This was a proposal we were trying to get some preliminary data for. And so they basically used organoids. So these are brain organoids that they treated with acetaminophen when they were 30 days old. At 2 different doses, and these results are completely uninterpretable to me. This was to generate pilot data, but we've seen organoids used for other exposures, alcohol, opioids, a lot of other things. And so moving into this space where we remove kind of all maternal and environmental and those kinds of confounding factors and just look at, does acetaminophen affect brain development? In my mind, is a really good area to go. And it also pulls us back from, trying to understand, is excessive grooming the same as ADHD in a mouse and that kind of stuff. And so the organoid angle, I think, is a really interesting space. And then the last thing that I don't actually have any examples of here, but using newer design or different designs like negative controls. So if you see an association with maternal acetaminophen and ADHD, and you have a measure of the dad's acetaminophen that should not be causing the child's ADHD, and you run those models and still see an effect, then you're likely in a space of, kind of that confounding by family level factors or environmental factors. So you can use paternal information, you can use pre-pregnancy acetaminophen exposure or postnatal exposure to the mom. As also negative control periods. This is assuming, though, that you don't just basically have the exact same use across all periods by mom. But so exploring kind of negative control areas are also ways that we can start to get at some of those family level factors and other such things that I just don't think we're doing a very good job of controlling in the large cohort studies. So to summarize where we are, so there's this growing and consistent literature that reports acetaminophen in pregnancy is associated with adverse neurodevelopment, primarily around ADHD. I will say I didn't show any of it, but the evidence is much, much less for autism and the other outcomes looked at. Systematic bias, primarily around exchangeability, cannot be ruled out. I didn't talk a whole lot about information bias. There has been kind of this move to use physician diagnosed ADHD as opposed to maternal report, which is a good step, but there can still be bias there if, someone is more likely to have their child evaluated who also was more likely to have used a lot of acetaminophen. Different study designs, I think, need to establish causality. I don't think continuing to repeat or synthesize this, the same types of studies are going to move the needle on trying to establish causality here. All right, so that is it for me, and I'm happy to take any questions.
Thank you, Gretchen. It was a very interesting discussion and overview. We have a few questions in the chat already, if you can see those, I believe. And then if others have questions, feel free to raise your hand or put them in the Q&A box, and we will call on you. So our first question's from Carol Allergat. For the Boston cohort you talked about, which was that high quality study in the review, the PK data also reflect the use of acetaminophen in the very days before delivery. So it's quite different from some of the, and probably indication dependent. Is there a certainty on exposure, there is indeed a certainty on exposure, but it's really limited in that time to the peripartum.
Yeah, I agree. And, the other kind of thing with that study is actually all samples had at least traces of kind of the metabolites of acetaminophen. And so it's hard to understand that. I mean, I think there were explanations given to like, well, everyone is exposed to some acetaminophen, whether it's like through, I don't know, water sources or what. But it is true. Most of the acetaminophen they're picking up is probably use that was very close to delivery. So I definitely agree that while it does remove that recall, there's a lot of question about what you're actually measuring in those PK samples.
And then I guess following up on that, is there any evidence on the timing of when acetaminophen is used in pregnancy? I mean, it seems like everything's so variable now that we don't really have good information on that. And then there were a couple of comments from James Adams in the Q&A. One referring to, could you compare the rate of use of acetaminophen versus ibuprofen or other pain medications as a risk factor?
Yeah, so that's an interesting question. It's a good question, and it's been attempted before. The one thing that's really difficult is that the use of ibuprofen and NSAIDs drop off pretty dramatically. And I took out a slide for time that we just recently published on NSAID use across gestation. And basically what you see is right around that first trimester, NSAID use really drops off dramatically, and acetaminophen keeps going all the way across gestation. And so you could look at very early pregnancy use and contrast the two, but particularly once you get out past kind of that 12th week of gestation, we probably just don't have the sample to be able to compare to ibuprofen because it's just not being used as much.
Another comment by James Adams. Acetaminophen is sulfated to detoxify it, and children with autism have been shown to have an impaired sulfation ability. In several studies, is there a connection between that or evidence of that in the parents where there may be a relationship?
I honestly haven't come across that at all. Yeah, it's an interesting point. It's not something that's kind of come up in the epi studies.
And then is there, from Irving Steinberg, is there any look at the impact of cumulative use of acetaminophen in breastfeeding added to pregnancy use for the longitudinal impact?
Yeah, that's a really good question. And similar to ACOG, what they also pointed out is that children's brains keep developing rapidly through about 15 months postnatal. And at that point, kids may also just be taking acetaminophen, especially if parents who are more likely to use acetaminophen also are more likely to give their children acetaminophen. And I haven't seen studies that are kind of looking at that cumulative exposure model of what's coming through breast milk and then what's being directly given to the child.
So I guess, one of the comments in the chat is then also, how would you, relating to counseling of mothers who might be concerned, what pain medication would you recommend during pregnancy, or how would you counsel a patient?
Yeah, I mean, and I think even in that consensus statement, they kind of still came back around to acetaminophen is still the preferred over-the-counter analgesic in pregnancy. And even for non-over-the-counter, we know that oral corticosteroids are associated with different adverse pregnancy outcomes. Opioids have obviously been studied for a whole, host of different outcomes, to the mom and the baby. And so I think that acetaminophen does remain the preferred analgesic. And, that common advice that's given by everyone that it should be used only when needed at the lowest dose for the lowest durations remains, I think, the advice.
Christina, I've promoted you, so you should be able to ask a question.
Yes, hi. Thank you so much for such a great talk. I was wondering if you noticed any associations between the amount of acetaminophen that was taken in terms of quantitative values for mothers who took it for fever versus any other one of the indications that it might be used for.
Yeah, let me flip back to my slide on that. So fever tended to be towards the top. So the top were people who were taking it for RA, were using the highest kind of average dose at 1,200 milligrams a day, followed by sleep, just because Tylenol PM has a lot of acetaminophen in it, at 1,000, and then fever was third at 900. So fever did tend to be one of the things that had the higher dose. It just had a shorter duration.
Thank you.
Dr. Elliott is thanking you for your talk and also saying that the EMA has a very similar revised statement on acetaminophen during pregnancy as the FDA does. So thanks, Carol. So great. If I don't see any additional questions in the Q&A or any hands raised. So with that, we will thank Dr. Bandoli for her presentation today and thank all of our attendees. This concludes our MPRINT Webinar Series for this year. We will take our summer hiatus and we look forward to seeing you again in the fall. Thank you.
Thank you.